alopecia. Excessive hair shedding and or spasming leading to visible scalp that may be either patchy or diffuse. History and examination. Elicit history pertaining to duration and age of onset of hair loss, whether patchy or diffuse scalp involvement, and if other hair bearing areas are affected. Relevant medical history pertaining to specific entities mentioned below. Hair care practices including cosmetic hair procedures. Examine scalp for scarring versus non-scarring by looking for loss of skin markings, loss of hair follicle ostia, pigmentary changes. Non-scarring alopecia includes congenital and acquired. Acquired is of two types, patchy and diffuse. Patchy alopecia includes alopecia areata, tinea capitis, and trichotillomania. Diffuse non-scarring alopecia includes telogen effluvium and pattern hair loss. Pattern hair loss is of two types, androgenic alopecia in males and female pattern hair loss. Scarring alopecia includes primary and secondary. Primary, there are two types, pustules or boggy lesions and pigmentary changes. Under pustules or boggy lesions, there is folliculitis decalvans and pigmentary changes includes lichen planopilaris and discoid lupus erythematosus. Non-scarring alopecia. Non-scarring alopecia is smooth, bald areas with small black intact hair follicles. First is congenital. Alopecia due to inherited or congenital disorders with or without easy hair breakage. Congenital hypotrichosis, monolithics. Trichorexis nodosa, loose anagen hair syndrome, and woolly hair syndrome. Refer to tertiary center for further evaluation. Non-scarring alopecia. Acquired. Patchy type, alopecia areata, tinea capitis, and trichotillomania. Alopecia areata. Asymptomatic, single or multiple smooth bald patches can progress to involve whole scalp, that is alopecia totalis, or all body hairs, alopecia universalis. History of atopy, examine for nail pitting. Less than 50% of scalp, topical 0.05% betamethasone lotion OD, intralesional triamcinolone once in 2 to 4 weeks, 5 mg per ml for scalp and 2.5 mg per ml for beard or eyebrows, only for limited involvement. Topical minoxidil 5% OD. More than 50% of scalp or involvement of facial and body hairs or margin of occipital area. Refer to tertiary center to be worked up for immunosuppressants such as oral steroids, minipulse, methotrexate or cyclosporine. Tinea capitis. Children with patches of hair loss with scaling and or signs of inflammation like erythema, pustulation, boggy swelling. Easy pluckability of hair within the patch. KOH mount for confirmation if available. Oral antifungals, griseofulvin 10 to 20 mg per kilogram, terbinafine 5 mg per kilogram for 6 to 8 weeks. Topical antifungal shampoos, avoid comb sharing. Trichotillomania, children or young adults with bizarre-shaped bald patches with broken hair of different length and focal scalp hemorrhages. Look for other signs of impulsive behavior, counseling and referral to psychiatrist if needed. Diffuse type, telogen effluvium, pattern hair loss, androgenetic alopecia in males, female pattern hair loss. Telogen effluvium, history to rule out underlying medical illness, drug intake, menstrual irregularities, hypo or hyperthyroidism, anemia, physical or mental stress. Labs, hemogram, and if indicated, serum ferritin, TSH. Reassurance and treatment of underlying disorder. If persistent, consider 1 ml of 5% topical minoxidil once a day. Androgenetic alopecia in males. Adult males with frontotemporal hairline thinning or recession, it may progressively involve vertex and parietal areas with usual sparing of occipital area. Treat with 1 ml of topical 5% minoxidil solution BD. If effective, continue this treatment to maintain hair growth. Addition of oral finasteride 1 mg per day may be considered. Can be referred to trained specialist for hair transplant if required. Female pattern hair loss. Hair thinning with widening of partition usually in postmenopausal women. In premenopausal, look for signs of hyperandrogenism. If present, hormonal workup to rule out PCOS or virilizing tumors of ovary or adrenal glands. 1 ml of 5% minoxidil solution OD for local application. Treatment of underlying condition. Severe non-responsive cases refer to a tertiary care. Oral anti-androgens, finasteride, spironolactone, cyproterone acetate with oral contraceptives may be added. Scarring alopecia. Scarring alopecias are areas with fibrosis and damage to hair follicles. All cases of scarring alopecia must be referred to a dermatologist for histological confirmation and further management. Primary pustules or bogey lesions, folliculitis decalvans, dissecting cellulitis of scalp. Investigations include trichoscopy, scalp biopsy for histopathology. Treatment long term oral antibiotics, doxycycline or clindamycin for 10 to 12 weeks. Consider low dose oral steroids and isotretinoin. Pigmentary changes lichen planopilaris, discoid lupus erythematosus. Lichen planopilaris. Violaceous plaques and follicular plugs. Examine for lichen planus of other sites. Investigations, trichoscopy, scalp biopsy for histopathology. Treatment, oral steroid mini pulse with or without methotrexate or azathioprine or cyclosporin for halting active progression. Strict laboratory monitoring for any adverse drug events. For burnt out disease, wicks and camouflage. Discoid lupus erythematosus. Discoid lupus erythematosus to depigmented plaques with atrophy, scaling and follicular plaques. Investigations, trichoscopy, scalp biopsy for histopathology, direct immunofluorescence, workup to rule out SLE. Treatment, photoprotection, topical steroids, hydroxychloroquine, 5 mg per kilogram per day after baseline ocular examination, usually required for 6 to 12 months. Secondary, due to trauma or burns or dermatosis like morphea, pemphigus, neoplasms affecting the scalp. Investigation and treatment of underlying disorder. High regrowth potential with non-scarring alopecia, guarded regrowth potential with scarring alopecia. General hair care principles. Hair fall of up to 100 per day may be normal and need not cause alarm. Regular cleaning of scalp and hair with plain shampoo. Avoid hair oil application and damaging mechanical or chemical hair care procedures.